Most people with COVID-19 recover quickly, but a small percentage develop severe pneumonia. These people need to be admitted in a hospital where they may get oxygen and medication like dexamethasone. Now, can we use chest X-rays to find people with severe COVID-19? Or should we also use other tests? And can AI help? These were the questions we had half a year ago when COVID-19 became a pandemic. I am Bram van Ginneken, a scientific director of TheraLab, and I will explain what we did to address these questions. The big advantages of chest X-ray are that it is easy to use. Just position a patient and press a button. It's cheap and it's widely available all over the world. One of the companies in TheraLab, Delft Imaging, makes these ultra-portable X-ray units. An X-ray tube, a detector and a battery pack in a backpack. You can even take it to places where there are no roads. A drawback of chest X-ray, compared to three-dimensional chest CT scans, is that on an X-ray everything is projected on top of each other. So the pneumonia changes in the lungs due to COVID-19 may be clearly visible on CT, but they are much harder to spot on an X-ray. It is also more difficult to see the difference between abnormalities from COVID-19 pneumonia and abnormalities from other diseases. For example, a regular bacterial or viral pneumonia or another lung disease. So how good is X-ray? As data scientists, we like to look at numbers. We have conducted an observer study. We asked 6 radiologists to look at chest X-rays of 454 patients who arrived at the Jeroen Bosch Hospital in Den Bosch during the peak of the pandemic. About half of them were positive for COVID-19. And we asked the radiologists to say if they thought the image was very likely COVID, possibly COVID, abnormal but unlikely COVID, or just normal. So 4 choices, and then you get for each reader 3 operating points, a pair of sensitivity specificity. And you can plot these points in ROC space. Sensitivity on the vertical axis and 1 minus specificity, so the probability of a false alarm, on the horizontal axis. So you want to be in the upper left of this graph. And here you see a cluster of 4 points. 4 radiologists could pick about 60% of the COVID-19 patients with a very low false alarm rate. The best radiologist found 60% of the COVID patients and only declared less than 10% of the non-COVID patients positive. The other 3 had 10 to 15% false alarm. But 2 other radiologists had always more false alarms, although they were also a bit more sensitive. Now, from all these points, you can conclude that chest X-rays scored by radiologists are not useless, but it is also far from a perfect test. Now, most research shows that with PCR, that's the gold standard for diagnosing COVID-19, but it's much more time consuming than a chest X-ray, you get about 80% sensitivity with 1 or 2% false alarm rate. So the main question we had now was, could an AI system analyzing these X-rays get the same performance as radiologists, or maybe even better? But before considering that, it is good to point out that COVID-19 is a global problem. Many studies show that the negative consequences of the pandemic in poorer countries will be far larger than in richer countries. And in poor countries, there is another infectious lung disease that kills 2 million people every year, tuberculosis. That is comparable to the death rate due to COVID-19, but TB happens every year. And in fact, the TB death rate will rise as a result of the corona crisis. Now, X-ray screening is an established method to screen for TB. And in Delft Imaging and Thirona, the 2 companies in TheraLab, we have developed an AI solution for this, called Cut4TB. So we realized that the role of X-ray in the COVID-19 pandemic could be especially important in countries where people with lung disease are already examined with chest X-ray to detect or rule out tuberculosis. Basically, from now on, every X-ray should be analyzed for both TB and COVID-19. Thirona quickly adapted their Cut4TB software to detect COVID-19, using as much data as they could collect in a short time period, and also using X-rays from patients with regular pneumonia. They called this product Cut4COVID X-ray. Now, here is the result if we plot the performance of Cut4COVID X-ray on this dataset of 454 patients of the Jeroen Bosch Hospital, for which we had the results of the 6 radiologists. Now, Cut4COVID X-ray had not seen any data from this hospital before. And you see that the software at the setting of around 60% sensitivity and low false alarm rate is comparable to the radiologist. At the higher sensitivity settings, the AI system even outperforms the human readers. Keelan Murphy, a postdoc in Thirolab, published these results in Radiology. But while we were doing this research, we learned about models that were able to accurately detect COVID-19 using blood markers, routine laboratory markers that a physician can also very quickly obtain, just like a chest X-ray. And at the same time, we obtained funding and we are now involved in screening programs in Africa, in Lesotho, Zambia and Uganda, where combined screening of tuberculosis and COVID-19 is now set up. And therefore, we started to implement AI systems that analyze both X-rays and lab parameters. The challenge here is that different sites tend to collect different blood parameters. Many different machines, every site does something else. The number of possible combinations is enormous. So we need an AI solution that can deal very well with missing features. In the next lecture, you will hear about this research that is still ongoing within Thirolab.